afternoon. Welcome to today's webinar event. My name is Emily Walter. I'm the Deputy CEO and now the Acting CEO here at Mental Health Victoria. It's an honor to welcome you all today. Before we get started with the Hamilton Centre introductions, on behalf of Mental Health Victoria, I'd like to acknowledge the traditional owners and custodians of the land from which I present to you today. Today, I'm on the lands of the Wurundjeri people of the Kulin Nation. So I'd like to pay my respect to elders past and present, and would like to extend the reminder as well that sovereignty has never been ceded. In addition, I'd like to recognize the voice of those with lived or living experience and acknowledge the importance of this perspective in the way it informs the work we do today. To those joining us with lived or living experience, including families and carers, thank you for your support and tireless efforts towards system reform and change. So I'm going to introduce our guests today on the screen in the correct order, I believe. First, we have Associate Professor Shalini Arunogiri. Shalini is the Clinical Director of the Hamilton Centre. She is a clinical addiction psychiatrist and researcher, and the Clinical Director of the Hamilton Centre, Victorian Statewide Centre for Addiction and Mental Health at Turning Point. Hi, Tioni. Shalini is also an associate professor at Monash University. She's the chair of RADSCAP Faculty of Addiction Psychiatry, a board member for the International Society of Addiction Medicine, and NHMRC Emerging Leader Fellow at Monash Addiction Research Center. She has over 50 peer-reviewed publications and over $14 million in research funding following the completion of her PhD in methamphetamine psychosis. Her work focuses on innovative pharmacological and psychosocial treatments for addiction, and she's also completing a fellowship in the treatment of trauma in people with methamphetamine use disorder. Shalini, we were just talking about your bio as a team. It's outstanding. Next, we have Lisa Jarvie. Lisa is the Clinical Quality Improvement Lead at the Hamilton Centre. Lisa has a track record of statewide projects at health service and department level before spending 10 years championing interdisciplinary care in pain management. She completed a Master of Addictive Behaviors in 2022, continuing research into pain, sleep, and substance use. She's now joined Turning Point as the Clinical Quality Improvement Lead of the Hamilton Centre. And last but not least, of course, we have Dr. Katrin Oliver. Katrin is the Education and Training Lead at the Hamilton Centre. She's an accredited mental health social worker and clinical academic with clinical and leadership experience within the AOD sector. Katrin has a unique blend of clinical social work, AOD, and mental health expertise, clinical leadership within community settings, health education design and delivery, and qualitative research skills. Thanks, Kat, for your organization of today's webinar as well in collaboration with myself. That's all for intros. I'm going to hand it over to the team at the Hamilton Centre. We will have, I think, about 5 to 10 minutes for Q&A. Maybe I'm overestimating. It's probably closer to 5 minutes for Q&A at the end of today's session. So if you send any questions through the Q&A function on the bottom of your screen, I'll be filtering through them and I'll pass them over to the team. We should be done, I assume, with the webinar by about 2 p.m. AEST, but we'll see how we go, okay? Over to you, Shalini. Thank you.
Thanks so much, Emily, and a huge thank you to Mental Health Victoria for running this webinar in collaboration with our team. We're really excited to share some information with you today. Just start off by making sure you can see that. All good? So we'll get kicked off. So all three of us are going to be talking to you today about the work we've been doing at the Hamilton Centre. And some of you may have heard of us, some of you may not. And so today we really want to be able to share with you a little bit about what our work has been for the first sort of 12 to 14 months of delivery. I'm sharing from Bunurong land today. Actually, the work that you'll see today was largely conducted on the land of the Wurundjeri people, but today I'm on Bunurong land. And so just echoing the acknowledgement of country that Emily did just before and acknowledging that sovereignty was never ceded. So in terms of the work that we've been doing at the Hamilton Centre, this is one of the Royal Commission recommendations, and cast your mind back to 2019. That's when the Royal Commission into Victoria's mental health system initially took place, and there were 65 recommendations to come out of that. The recommendations that we observed are related to number 36 and also to some extent number 35. which is related to integrated care transformation within area mental health services. The context for this is really probably no surprise to anyone who works in the sector. 1 in 5 people will experience mental illness across the populations, but really the system that we have currently in Victoria isn't prepared for current or future challenges. And one of the challenges within the context of co-occurring mental illness and drug and alcohol problems is that the systems that are in place, not just here in Victoria, but really across Australia and internationally, have been really quite siloed. They've grown and evolved over time to be in parallel rather than working together. And as a result of that, we have a lot of people who have had to fall through the gaps between those two systems, who also experience what we refer to as double stigma of having those challenges of seeking help from the drug and alcohol system, as well as seeking help from the mental health system and experiencing those barriers being compounded. That context in terms of prevalence here in Australia, if you look at just drug and alcohol services, for instance, we know that the vast majority, probably 66% here, is probably an underestimate, but is based on kind of the most recent data really suggests that, about 2/3 of our clients are really presenting with co-occurring mental health problems. And then if we look at area mental health services or public tertiary mental health services, again, that's almost half of our current clients are presenting with co-occurring problems. So across the board, that's the context for which we look at integrated care transformation. It's acknowledging that co-occurring disorders are really that expectation rather than the exception. So in terms of what the recommendations were in number 35 and 36, was to think about what a system of care would look like that supported that statement, that supports the idea that everyone is possibly likely to have that co-occurring combination, and how do we actually create services that are welcoming, that are non-judgmental, that allow and enable people to access the best care. And there are a number of different kind of key points that have come out of those recommendations. Some of this is also work that has drawn on international literature, because this is really a space that's kind of evolved over the last probably 4 or 5 decades in understanding how we support comorbidity care. And some of the key points that have come through in that literature is the idea of a single point of engagement, really supporting people when they seek help, where they seek help. And if that integrated care kind of full spectrum of services isn't accessible within that one service, then finding ways in order to work with other services on the back end, back of house, trying to set up those linkages, those warm referrals, working as a team with a team approach to be able to provide care to an individual. And also being able to flex that according to someone's needs. And that might vary significantly across the lifespan, across a range of different diversity or trauma exposure, or a whole range of different kind of previous needs that people might have also presented with. Also thinking about the social and welfare sectors here and how that also interfaces within the drug and alcohol and mental health system. So thinking about housing needs, family violence supports, and a whole range of other challenges people might have experienced. But that key point of really thinking about no one being excluded from services because of co-occurring needs, no one being excluded because the door that they come in may not lead directly to the most highest priority need. It's about being able to work with people to be able to provide that. And so also, encouraging and enhancing the philosophies and spirit and the concepts that sit behind both the mental health and wellbeing sector and the drug and alcohol treatment sector, recognizing that they both have unique strengths and unique skill sets as well, that they both draw from a unique kind of and distinct evidence base too. So wanting to kind of maintain those kind of streams. So coming out of that, our initiative is a statewide initiative. It's one of a couple of statewide initiatives to come out of the Royal Commission, and it's being looked at across the whole of the state of Victoria, thinking about how we have research, education and training, and clinical service delivery across the whole state. That includes a range of the metropolitan services as well as rural and regional settings across Victoria. And we'll talk a little bit, I'll touch a little bit about the clinical service delivery, but we'll hand over to my colleagues, Lisa and Kat, to take you through some of that in a bit more detail, but the clinical network and what they do, and also our education, training and research functions. In terms of kind of some of the background that led to this work, I wanted to share some of this with you to give you a sense of the journey that we've been on to land at the model we have now. This consultation and co-design work was undertaken at the end of 2022 and across 2023. and undertaken in partnership with the team at Monash University, Monash Design Health Collab. And so the methodology that that team utilized was to look at a consultation process that was sector-wide. Mental Health Victoria were also participants in that process, and there were a whole range of different services that participated from drug and alcohol backgrounds, mental health backgrounds, peer support across both streams, and lived experience advocates from both mental health, AOD, and the joint kind of comorbidity spectrum as well, and also looking at consumers and carriers in that space. And when we brought people together, what we really wanted to do is kind of understand how people were accessing systems as they were as it stood, and then thinking about a future state, how people would actually access care if it were to be integrated. The methodology was designed within this kind of concept and framework. It's a digital workshop online, but utilized this tactile tools method, which really grounded a lot of the discussion in the journeys of these stories. And so we had 4 stories. They were designed around what we were thinking would be realistic and accurate kind of representations of people who are accessing care across Victoria. So a lot of kind of thought went into the design, and we also were able to test the design and the stories through the co-design method. Really looking at kind of diversity in terms of different ways that people might be accessing the system, diversity in terms of background, diversity in terms of intersectionality and different barriers that people might experience, and then also thinking about different diagnostic kind of frameworks as well. So these materials are available on our website, as well as the whole report that went for the co-design method. So really encourage people to have a look if you're interested in this. And so through those workshops, we had 3 workshops in the end. And so the first couple were looking at those journeys and understanding how people actually interface with the treatment system. And then the second workshop was starting to actually drill down on what capability looks like within the current state and how we move towards an integrated care state. We asked people to kind of really think quite deeply about enablers and barriers to integrated care, and acknowledging that a lot of work has already happened in this space in Victoria to enable integrated care prior to the Royal Commission being in place. So wanting to build on that existing work and understand the current contemporary state. What are these enablers and barriers now? What are the system levers that we need to think about as well to enable people in the workforce to do their best work? Also, I think one of the key themes that we also touched on was what needed to happen in terms of enablement of change. For many people who work in the sector, change has really become sort of very much part of the framework for probably the last decade, really. But the last 5 years coming out of COVID and then subsequently the Royal Commission implementation, I think we're really kind of understanding what is going to be feasible, what's achievable, how do we actually create sustainable change as well. So this is just a snapshot of some of that methodology that was grounded in the story of Mary, who's presenting with sort of trauma symptoms, PTSD, and trying to access care, and also presents with GHB use. And so we had a range of different kind of discussions, and the qualitative methodology, again, available in our report, is online. Just wanted to give you a bit of a sense of some of the key insights we had through that process. And this also then went to drive our model of care that Lisa will talk a little bit more about, and was really kind of pivotal in kind of helping us decide how we create education and training material that's kind of current and relevant to what we are hearing. So these one-page documents are on our website and really highlighted those principles that needed to be there, the front of house, as soon as someone walks in the door, that they're actually coming in to a service that's welcoming, that's non-judgmental, where they feel like they're being heard and that the whole of their story is being heard, that people are being heard as a whole person. Also trying to find ways to minimize those barriers to care and access, minimizing touch points where people were having to retell their story multiple times, and having duplication of form filling, for instance, in different pathways. And also thinking about inclusion of family and carers and supporters in this process, and finding opportunities to integrate that process into existing workflows as well. And so some of the actionable insights, this was just that key point that we were talking about around stigma and engagement. Some of these actionable insights were kind of coming through quite strongly, including a real focus on the lived and lived experience workforce that's both within mental health and AOD, and encouraging services to try and think about how to enable peer workers to be able to make that initial contact and to be able to welcome people into the service in that way. The full reports are on our website, and In terms of just giving you a little bit of a picture of where we're at in the first 12 months, I'll just touch on what the overall model looks like for our clinical service delivery and then hand over to Lisa. So overall, we've got a central team and that operates within a network across the state. Our central team are based at Richmond, at Turning Point in Richmond. And our central team have some core functions that are around sort of leadership and advocacy in the space. We operate the referral portal and take referrals across the state to our network and coordinate those referrals. We also operate an advice and mentorship line that Lisa will tell you a bit more about. And we have key functions in terms of education and training for the whole of the workforce, that's both mental health and AOD workforce, and also research functions in that space. And we are starting to grow lived and living experience advocacy as well within integrated care. So this gives you a little snapshot of what our current existing network catchments look like. So as you can see, many of these services are quite large catchments, and with the exception of Austin and Goulburn Valley, who are working together in partnership, the rest of the services are largely metropolitan. So you can kind of see that this is can be a challenge to kind of think flexibly about how we offer models of care that are going to be adaptive and going to be actually able to offer something of use that's adapted to the needs of the community. Many of our teams have spent the majority of the first year really in consultation and engagement with services in their catchments to be able to kind of figure out, well, who's on the ground, what's available in the local community, how do we adapt the care that we offer accordingly. And so these are the main sort of clinical service deliverables that are available to people across the state. And just highlighting, if you're a worker in really many parts of the service system now, you can give us a ring to kind of navigate through the system. Our first initial port of call was area mental health and wellbeing services. So all clinicians and workers in area services are able to ring us or give us a referral across the state. And that's for both primary and secondary consultations. In terms of kind of ongoing care, that is largely kind of still held by the community teams, the area services that see people. And then we're starting to also then expand now into locals and drug and alcohol services, starting with residential services as that first protocol. That expansion of the clinical network, hopefully in the coming years, will include larger kind of tractions of the state as well. So since our launch, just over a year ago, we've had 900 referrals across our central team and our network. Approximately about 30 to 40% are from rural and regional services, and but a really wide variety of needs kind of coming through. As I mentioned before, the network and the staffing profile of the network has largely been medical and focused on addiction medicine, addiction psychiatry, nurse practitioners, nurse practitioner candidates as well. Nurses across the spectrum, and then also trainees within this space. And we've had peer workers now onboarded across our teams. And so that staffing profile works alongside the existing drug and alcohol treatment sector to be able to offer care. And so the focus of those care plans is often kind of understanding what those holistic needs might look like across the sort of biopsychosocial spectrum, and also thinking about care coordination and prioritization. So which of these needs that someone's presenting with might be most urgent, might be most useful to address right now. We also have a whole range of outreach engagement within rural and regional services to be able to support capacity downstream and create sort of sustainable mechanisms for teams to support their local clinicians as well. So that's me done with my slides. I'm going to hand over to Lisa to take you through some of the clinical deliverables in a bit more detail. So I'll stop sharing and Lisa can start.
Thank you, Shalini. And I will preface this by apologising for some oddities happening with my font, and I hope it's easy enough to read as we go through. So we're going to talk a little bit now about how do we put this into practice and what does integrated care look like on the ground. A quote from the Royal Commission final report, I think, underpins a lot of the work that we're doing, which is that people living with mental illness and other conditions such as addiction can find it particularly difficult to gain access to services. This is because these services are often not sufficiently integrated to respond to people's needs and preferences. And as we all know, clinically, these are very changeable needs and preferences. It's not consistent through somebody's journey and interaction with the healthcare system. When we will hopefully send out these slides, and I'd encourage you to have a look at this in a little bit of detail. It's looking at the barriers and enablers to implementing integrated care. And this was from the consultation. So this has come out of the Hamilton Centre consultation that Shalini was discussing. It looked at what are the barriers and enablers at an individual, workforce and systems level. And this is when we're going back, there are a lot of issues at the system level that we might not be able to impact as a clinician on the ground, but there are certainly things that we can address within ourselves, looking at shared care plans, looking at relationship building, role clarity, looking at our own attitudes, mindsets and behaviours as well. This diagram is part of a poster series that is available on our website, so you can have a look at that and consider whether which elements particularly stand out to you and your organisation. The 6 levels of ongoing support for people with co-occurring mental health, substance use or addiction also comes out of that Royal Commission report. And we're looking at levels at the very baseline of families, carers, supporters, informal supports, all the way up to sort of the statewide services, which is at the moment the Hamilton Centre. Other statewide services include the new trauma service, the statewide trauma service, which in conjunction with the APS, the Australian Psychological Society, will be doing some training around trauma-informed care. You can see there at around level 4 and level 5 are the mental health and wellbeing locals and the area mental health and wellbeing services. And AOD services are on this diagram as being a group of organisations that do provide care for people with co-occurring conditions, but generally at the lower intensity of mental health concerns. So what's happening to make this an integrated service system? So as I said, there's not a lot we can do on the ground to make systems integrate. So what are the department doing to make some of these changes? There's been funding to a large number of area mental health and wellbeing services to look at local options for enhancing integrated care. As Shalini was saying, there are really great opportunities for internal integration within the larger services. Apart from that, there's the mental health and wellbeing locals that are being implemented across the state, the mental health and AOD emergency hubs, and the statewide integrated services such as the Hamilton Centre. I'm hoping that most of you have had a look at what your mental health and wellbeing locals are, but just as a very brief overview, they're being established across the state on an LGA basis, and that establishment started in 2021. The initial completion date of that rollout was to be 2026, but it's been pushed out slightly due to changes in the budget, and we'll be watching this space. Generally, these are services for adults, so aged 26 to 65, who are experiencing mental health and wellbeing concerns. It also includes people who are experiencing co-occurring conditions. It's free, you don't need a referral, and you don't need a mental health care plan or even a Medicare card. So the locals are really accessible. They're, as their name suggests, they're local, they're in your area, and they are being stood up gradually across the state. What I would really encourage you to do is have a look at the Better Health channel or the department's website and look at what your local is. A lot of these are being run by quite large organisations, and they might be involved across multiple locals throughout the state. But have a look at where your local is and how well established it is. They vary quite dramatically at the moment because of the different levels of establishment. They have different service offerings, different models of care, depending on where they're located and what their community partnerships are. Many of these locals have a largely peer-led workforce. Entrance to the service is predominantly facilitated by peer workers. Most of the services that we've talked to have about 50% peer workforce. So have a look, find out whether your local has been stood up all the way yet, or whether they've just got a phone line, and get in touch with how your clients may or may not be accessing the locals. If there's anyone here who works from a local, it's fantastic. I'm really excited to see what you do in this space. We're definitely excited about it. Another part of the integrated care stand-up was the mental health and AOD emergency hubs. So 6 emergency department hubs have been stood up across the state, or Frankston Hospital is due for completion later this year. And this was directly responding to an increasing number of people with mental health, drug and alcohol problems who need help in emergency departments when they've reached crisis point. So this means people presenting in emergency with mental health issues can be fast-tracked to specialist dedicated care, getting them the right support sooner and easing pressure on existing resources. It also decreases the stress and trauma related with attending emergency while you're in crisis. So that's what the department's doing to try and sort out some of our service system. What is integrated care? Integrated care is person-centred, it's holistic, it's goals-focused. Realise my font has made that look like God's focused. No, I mean goals-focused. It's awareness of your own service and what's around you, what supports have you got around you. It's smooth and seamless care transitions for clients. It's dependable relationships. It's client-focused and it's rewarding. And it should be our core business. So integrated care is not something else you just have to do in a very busy workday. It's not an expectation that everyone's going to be an expert in mental health and AOD. So how do we develop a shared understanding of what integrated care actually is? This diagram, and I will leave it up there for a little while so you can have time to have a read of it. It was developed again as part of that sector consultation by Monash University, and it speaks to the depth and importance of high-level expertise. It highlights the importance of a breadth of understanding of services and options for service for people with co-occurring conditions. And I want to again reassure you that we're not expecting or even asking you to become experts in substance use or addiction overnight or even at all. It's expecting and respecting the high level expertise you have in your area of care. What we do have across the AOD and mental health sectors is we have a specific expertise and interest, but you're absolutely an expert in sitting with people with distress. So clients will present to you with distress in a range of settings: pain, trauma, substance use, mental health, and you will be equally as expert in every setting. An AOD expert is going to need your mental health expertise to support them with delivering integrated care, as you will with their expertise. This model encourages to look beyond our expertise and ensure the person sitting with us feels supported, valued, and in control of their care. We value the relationships created between the service user and the service, and often continuous outgoing referrals undermine those relationships. Integrated care, or bringing the care into where we need it, or supporting client transitions in an informed, supportive way. So this T-shaped model enables the client to receive their care they need while we embrace what we know, and we link with services that can provide things outside our area of expertise. It means that we can embrace it whether we have local experts or not. So this is looking beyond that co-location, which is, the ideal of integrated care is to have everybody co-located. That's not unfortunately, that's not possible in many settings. The next thing I'm going to do is just go briefly through an example of integrated care where a vulnerable client was at a key transition point with established and valued relationships, and how accessing other services can smooth that transition, reducing risk to the client. Obviously, as I said, there are many ways to provide integrated care, and it might be something that you do have internal supports to facilitate. And if you aren't sure where you would access support for this sort of situation, that's where we can help. That's where the Hamilton Centre can be on the phone with you, or you can make a direct referral to us if you can. So I'm going to talk to you a little bit about Amy. Obviously, that's not a real name. Amy is currently residing in public housing prior to going into the SECU. So he's currently an 18-month resident of secure extended care. Amy has a history of schizoaffective disorder, which is complicated by substance use, mostly methamphetamine. She's vulnerable to exploitation and is engaged in sex work in the past, and can be easily coerced by others into engaging with substance use. She's lost 2 public housing tenancies due to squatters being involved, and is a non-custodial mother of a 10-year-old child. Coming up to discharge from SECU, with a focus on discharge planning to the community care unit, the referring team made a referral into the Hamilton Centre to facilitate this transition. The referral goals are around coordination of care and system navigation, including recommendations regarding potential detox, any rehabilitation that might be needed, coordination of counselling and psychosocial care, and in connection to peer support. They were asking for an opinion about psychotropic regimen, interaction with substance use, and/or a substance use disorder medication regimen. They were asking for assistance with looking at safeguarding and mitigating risk around vulnerabilities when it comes to substance use, especially around stable housing. So that's when we're looking at that T-shape, we're looking beyond medical care. They were looking to work with Amy around harm minimisation strategies to support discharge and transition back to community. And they were also looking for support to the treating team and the NDIS workers in supporting this client when she was discharged from SECU. On the flip side, the consumer was very open about a desire to continue substance use, and that abstinence was not a part of her future. She had long-term goals around harm minimisation and occasional use of methamphetamine. She didn't want formal AOD supports. She thought she might consider AOD peer support, but didn't want to be referred to AOD services. So the question there was, how does a mental health community team continue to support Amy in the community, knowing that her complicated schizoaffective disorder is further worsened should she return to regular methamphetamine use?
Hello, everyone, and I feel for you, Lisa. That's hard work. So thank you, everyone, for understanding. I am going to share my screen, so hopefully everybody can see that. This framework highlights the 15 capabilities, which are the knowledge and skills required to deliver safe and effective care and support. So the capabilities are described for the whole of workforce, including admin, educators, care, support and treatment professionals, as well as specialists and leaders. So these capabilities are based on 7 principles that provide a common set of core values, approaches, attitudes and ways of working that underpin all interactions between professionals, consumers, carers and families. If you can, next slide, Shalini, please. So this second graphic represents the capabilities in the blue in that outer ring, and the 7 principles in green. So these both encircle the consumers, supporters and the community in the centre there. So I'm not going to go into these in detail, but I encourage you to have a look at the Department of Health website when you can. Next slide. Yep. So what I am going to do is talk a little bit about capability 6, because this is one that's particularly relevant for the integrated AOD and mental health. So capability 6 is about the mental health workforce understanding and responding to substance use and addiction. It highlights that people experiencing psychological distress or mental illness often have intersecting needs and preferences. And it notes the importance of recognising the prevalence of co-occurring conditions and making sure that substance use and addiction is integrated with the support for their other mental health conditions. So the Workforce Capability Framework is referenced across various statewide training platforms, including the Centre for Mental Health Learning, VADA and the Hamilton Centre. So, for example, the Centre for Mental Health Learning, on their platform for training, you can filter by capability. I want to bear in mind that the Centre for Mental Health Learning is funded to provide training for the mental health workforce, and VADA provides training primarily for the AOD workforce. So it's important to check the eligibility criteria for any training that you'd like to enrol in. Overall, the mental health, this capability framework, it speaks to best practice, so it's relevant from that perspective for both sectors. Next slide. So the Department of Health has also drafted an AOD workforce capability framework, and this, when finalised, will sit alongside the mental health one. The AOD framework describes the knowledge and skills that AOD workforce needs to provide support to people, and it's intended as a resource, not an additional requirement. And it addresses the needs of the workers, the service providers and leaders, and education and training providers as well, and across government. Next slide, next one. Yep. It covers the foundations of care and treatment to support specific populations. It considers that how AOD intersects with other frameworks such as youth, forensic and family violence frameworks. It considers various elements of practice, including assessment and different types of interventions and contexts, and how to provide, how you can be supported as a worker. So keep an eye out again for when this is finalised. It will be published on the Department of Health website. Next slide. So coming to Hamilton Centre training, the frameworks that I've just mentioned give you the foundation for building relevant training for both the workforces. And the beauty of our brief at Hamilton Centre is that we're able to deliver training to both workforces. So while at times this training may feel like it's perhaps leaning in one direction or the other, all of the training is developed with integrated care in mind. So we've launched the full version of our website a few months ago, which we're really proud to have done. And you can find lots of great resources in different sections of our website. If you navigate to the the events and training page, you'll find links to our training as well as training by other providers in the space. So at the moment, we're showcasing training from VADA, Turning Point, Transforming Trauma Victoria, which is Phoenix, Australia. The Matilda Centre's comorbidity guidelines. There's training there from the Mental Health Professionals Network, Task Force and Spectrum. And we work really closely with these organisations to make sure that we select training that specifically addresses co-occurring conditions, and they're constantly updated as well. So on the page, you will find our Hamilton Centre specific training. We've got 2 online self-paced modules. One is Introduction to Co-occurring Conditions. The other one is Therapeutic Relationships. We're due to launch 2 more very soon. So the first one of those will be Opioid Pharmacotherapy, and the second one is Foundation of AOD Knowledge. So these are self-paced modules. They're free. You can start them off. If you don't get time to finish them within a couple of a time period, usually a couple of months, you'll get a gentle reminder from us to see if you can finish those off. And you can come back to the platform at any time and re-register if you need to. So yeah, I think that one. Next slide, Shalini, please. So when you click on that little register button that was on the previous one, and you are directed to a page that's hosted by Monash University and Guru Learning, and you need to provide just a little bit of information, and then you'll be directed to, next slide, a dashboard. Thank you, Shalini, where you can select which module you'd like to do. So this is a screenshot of what that looks like. And can you see there on the left-hand side, right-hand side, not sure on your screen, right-hand side, I think, that the modules are listed there, and you can click into which one that you would like to do. They take about an hour. There's some reflective exercises in there. They're designed for you to think about your own practice, but also to perhaps there's a set of questions in there that you can take to peer supervision or group supervision. So you can do it as a team as well. And they're meant to be a little bit like, questions at the part of a book club. You can talk about it amongst your group and see what that comes up for your specific team in your organisation, because everybody's going to be different. So some of them, some of the questions you may not have really thought about before. It would be worth exploring. At the end of each module, there's the option to download a certificate. That's a certificate of completion, and that may be suitable for some of you to use for professional development points, depending on your discipline. Next one. So this is just a little bit of a snapshot of what's coming in the next financial year. We've got a range of education planned, so there'll be in-person and online live workshops covering a range of topics. The topics will be chosen in consultation with the AOD and mental health, our key stakeholders across both mental health and AOD, and to make sure that they're relevant. So the workshops will be both metropolitan as well as in rural and regional areas. They'll be targeted towards clinical and community workers across the locals and AOD community, and they'll be co-designed and, where possible, delivered with lived and living experience workers as well. Next slide. So in the meantime, you can learn more about integrated care through our podcast series. We've got 2 episodes that are currently available, and there'll be some more coming soon. You can access these on our website and through our social media and through platforms such as Spotify, and I believe just about anywhere else you can find a podcast, we're there. So check those out. Next slide, Shalini. And of course, we've got webinars such as this, and hopefully the next one we do runs a bit more smoothly than this one. So we have got one on Friday that is kindly hosted by the Centre for Mental Health Learning. As far as I'm aware, that registrations are still open for that. And these webinars, as is this one, are recorded, so you can be watched on demand at a time to suit you if you can't make it on Friday. We hope to have more webinars in the new financial year as well. And I think it's going to go to the final slide, Shalini, for me, which hasn't come up quite properly because there's a thank you on there as well. But that's it from me. And once again, I do apologise. I promise it worked perfectly when I tested it with Emily. So thanks, Shalini, for driving. I hand it back to Lisa.
Thank you, and my apologies as well. I'm hoping to be able to finish this off now. So I'm sure you're all wondering what happened with Amy. So we'll go back to have a bit more of a chat about Amy. Thank you, Kat, for stepping in. And so unfortunately now we're going a little bit back in time, and just maybe you can have a think about all the things that Kat's just presented you with for how we could also bolster support around clients such as Amy. So the upshot of Amy's referral to the Hamilton Centre was the Hamilton Centre then proceeded with a secondary consultation. So because Amy was not particularly interested in linking in with formal AOD supports, she didn't undergo a primary consultation, and the support was largely to the treating team within the SECU. There was advice given around her medical care and medical management, both within the last few months. So this was a referral. The referral came 5 months prior to her discharge. So there was some support, medical support through addiction psychiatry, nursing, and also pharmacy throughout the last few months of her time in SECU. But also Amy was linked with the Hamilton Centre peer support worker who spent time with her while she was in SECU, and also had that focus on positive and affirmative support during that discharge transition. So the female Hamilton Centre peer support worker, coming in a trauma-informed way, was able to bridge support for Amy as she transitioned her primary care team to maintain that relationship, which is really key to continuing that involvement with healthcare services. They continued with that focus on goal setting and engaging with community supports, both up to and following Amy's discharge from SECU. She's continued with that engagement with peer support on transition to community, and is now well supported and well settled in with her community team. While she hasn't been discharged from the Hamilton Centre, her engagement is less frequent these days because she is feeling very well supported with that community team, and she still wants to be able to engage with that peer support worker should she need that support. So that's sort of the story of Amy and how she was supported through a referral to the Hamilton Centre. Regardless of the fact that she didn't want those formal AOD supports, we were still able to support her treating team and also support her through some peer workers. Because linking in with other supports can be really tricky. We don't know what's at the top of our T. We know what gaps we have in our own service, but we don't actually know how to access those community supports. Luckily for Amy, her support was within the one organisation. So it was bridging support and transition in care, but it was within one organisation. Sometimes if you are in an isolated organisation, it's really difficult to know how to access that sort of support and where to find the next part of the T. And this is where the Hamilton Centre can offer that sort of support. You can call us on our 1800 number and speak with a clinician who's an expert in service navigation, who, even if they don't have the answers, will be able to workshop this with you and spend the time necessary to make sure your client's care is as smooth as possible. So you can do that even if you can't refer your client directly to the Hamilton Centre. Shalini mentioned the advice and mentorship line. That's the same phone number. So the same clinicians can give you advice. They can provide some mentorship. If you haven't had to do, for example, a referral to a withdrawal service before, if you haven't done that and you wanted to talk through that process with someone, the experts at the Hamilton Centre can help you with those processes. And there's no silly question, there's no wrong question, there's no judgment when you call that line. It's purely there to be supportive for you. And they can, as I said, spend that time with you, get an immediate response during business hours, so that phone is staffed by the clinicians, or you can put an inquiry in through our referral page and someone will get back to you as soon as possible. Referring clients to the Hamilton Centre, as Shalini said, all areas of the area mental health and wellbeing services, mental health and wellbeing locals, and state-funded AOD residential rehabilitation and withdrawal services. And that's all done via our website. Kat has beautifully gone through all of the amazing opportunities that are available through our website as well. So there's the website information there. And if you would like to refer a client or request contact or information from us, that is also via the website through the referral and information form. And if you just want to speak to a member of the clinical team, and what I like to say is tap a colleague on the shoulder, the corridor consult that you might not have access to anymore, our 1-800 number is there, so you can tap that colleague on the shoulder. I'm going to stop the share now because we can actually go to questions now. Emily?
Thanks, Lisa. I have asked everyone if they had any questions, and I haven't seen any come through. So it's a bit of a speak now or forever hold your peace, I suppose, if anyone does have any questions online. Otherwise, we're basically on time anyway, so we can wrap it up if there are no heavy-hitting questions, I guess. Might just wait another minute. Make sure no alarms go off or anything. That's just the way. As I said, they always have impeccable timing. We can prepare for the dogs or the children, but not the alarm system sometimes.
Absolutely. On Friday with CMHL, I will be doing this from home, so we'll not run that risk again.
Look, there are no questions that have come through, so we might actually wrap up the webinar there if that sounds okay. Wonderful. Thank you so much, everyone, for attending. I did also want to say, on behalf of Mental Health Victoria, that our associates who are online today are more than welcome to contact MHV if you would also like to host a webinar alongside us, which will be ideally more educational than anything, but you do have that opportunity as an MHV associate to engage with us in the webinar capacity. There's just a question around TAFE colleges still having separate AOD, I think we meant, and mental health courses, whether or not that's still the case. I believe that is.
I believe
yes.
so. Yeah. As far as I'm aware, yeah.
Yeah, there's for example, the Cert 4 mental health or the Cert 4 mental health peer work, and AOD is unfortunately a little bit separate to that in most cases.
Yes.
There we go. Here's some questions. Is the intro to co-occurring disorders suitable for graduate allied health clinicians to meet some of their competency requirements? We have more technical questions around the courses. Do you have an answer to that one?
Yes, I think it would be a great start. Whether, I guess, the specifics around the requirements around their competencies, I mean, they would need to assess that, have that assessed themselves to work out how matched it is. But certainly jump on and have a look, and you can go through the list of topics. There's an index there, and you can have a look around, yeah, to see if it's going to meet the needs. Yeah.
Great. It looks like those, yeah, go on.
It is designed, you don't have to be a mental health worker or an AOD worker to do it. It will be suitable for lots of different allied health as well.
Wonderful. There's nothing else that's come through, so let's wrap it up there, shall we? Thank you again, Lisa, Shalini, and Kat, for your time and your presentations today. And good luck with the presentation on Friday as well with CMHL. Thanks so much.
Thanks so much.
Thank you, Emily.
Have a great afternoon. See ya.
Bye.
Bye.